Thank you so much for the invitation. And I have no financial disclosures for this talk. And just to give you first a little bit of the overview, Chile is a small country in South America, and we have a total of 171 patients in the country. We probably see, DebRA Chile sees probably all the patients with EB, and our prevalence is 10 per million inhabitants, and simplex EB is approximately half, and then dystrophic EB is approximately 4 per million. And our gender distribution is about half and half, and most of our age patients, go between 30 and below. Now, I'm going to show you a clinical series. This is a cohort of 140 patients that I've been following since March 98 when I got involved with this. We've seen patients from a newborn, obviously, to our oldest patients, that's 64 now. And when you consider what are the ocular manifestations of EB, well, like in the skin, we have blisters that we call bulla, conjunctival scarring. We also see conjunctival cysts, blepharitis, which I'm going to talk about in a little more detail later, conjunctivitis, which is what most people call pink eye, and most of the conjunctivitis we see is related to irritation or toxic irritation due to the skin descaling from the eyelids, and obviously you get some acute infections from the lid margin. And what this picture here shows is punctate epitheliopathy, which is basically damage to the surface cells of the cornea that we call epithelium. This is anterior blepharitis, and we call them collarettes. It's like dandruff, and it's a collection basically of staph epidermidis, and they are a source of infection, and they are particularly common in our patients with EB. And we also have a little bit, sometimes more severe problems, like recurrent corneal erosions. We can get a condition that we call inferior pannus, which is basically scarring over the cornea with blood vessels. We can also patients can develop scars on the transparent cornea. The cornea is the most important lens in the eye. It's like the first window. And when that gets opaque, we call those leucomas, and those decrease the visual acuity according to their location. As the more central they are, the more they're going to affect the vision. And it is a big problem in children because children can develop normal vision until they're about 8. So if you have something blocking their vision before that age, they're going to develop what most people know as a lazy eye, and we give the technical term as amblyopia. Obviously, the cornea can also be infected, sometimes severely, and we can also get corneal perforations. I don't know if this shows, maybe there's too much light here, but this is an inferior leucoma here. This is the pupil, and the pupil is not completely blocked. And unfortunately, I'm not sure if it shows very well, but this eye has a corneal perforation, and what you see there is the iris coming to the cornea, trying to block the perforation. Now, the severe ocular findings we find in EB are, like in the skin, squamous cell carcinoma, and the most severe condition we get is limbal stem cell deficiency, shortening of the conjunctival fornices, and Symblepharon I'm going to show you. That's actually a case of conjunctival squamous cell carcinoma, that lesion right there. And this is a patient that I did his surgery 10 days ago, and this is severe limbal stem cell deficiency. This patient gets a completely opaque cornea, and the cornea is filled with blood vessels, and it gets opaque. And this can't get better with normal corneal transplant because that'll become opaque immediately. And this is also a severe condition. It's called Symblepharon, and that's scarring between the mucosa of the eye, that's called the conjunctiva, and the eyelid. So this is my own classification, as other doctors have said. It's based on my experience and of what I've seen, and I've divided the eye involvement in EB into two categories, which I call indirect and direct. Indirect are lesions that are not directly related to the formation of the scarring, the conjunctiva or the ball, but basically we're talking about diseases that can happen in any particular patient but are more common in EB patients. And direct are lesions caused by the recurrent surface bulla and the scarring formation. Now, there is a sample that I've been following more closely. Those are 85 patients that I consider have a proper follow-up, of which 33 have a completely normal eye exam, and 52 of those 85 patients have what I call indirect involvement. That means this is not directly related to EB, and that's what we call epithelial lesions. And basically, those are caused by the infection of the eyelids, of the eyelashes, by the blepharitis. And other are ulcers or inflammations that are related to the presence of staph epidermidis. Like, for example, here you see this area that's an ulceration of the conjunctiva, and it stains green with fluorescence, with fluorescein, and that's basically caused by staph epidermidis, and any person can have that. It's just that it's more common in EB. Now, direct involvement, that means patients that have this because of the underlying genetic problem of EB. Those are 28 patients with bilateral disease that does affect their visual acuity. And of those, the most common reason that they come to visit us is because of pain and recurrent corneal erosions. Some of these patients can 10 have severe central leucomas that affect their vision. One eye that I showed you had a corneal perforation. 24 have mild or central or paracentral leucomas. 4 eyes with cysts, and 8 eyes with Symblepharon, which is the sticking of the lid and the surface of the eye. And the worst cases of all, that will show you how I resolved them, is 4 cases with severe limbal stem cell deficiency. So this is one of our patients, Braulio, and fortunately for him, he just has scarring in the lower part of the cornea, but his visual axis remains okay. And this is another of our patients that does have scarring leucomas that affects the central cornea. Now, what is the correlation between skin and eye? Well, at least what I have been able to find is that all patients that have severe involvement also have dystrophic EB with esophageal involvement. But on the other hand, not all the patients that have esophageal involvement have what we call direct ocular involvement. Now, there's no clinical correlation between the type of EB and the eye involvement, but what I can say is that simplex EB has no direct eye involvement. They do have a lot of symptoms, but symptoms related to what I call indirect. Now, sometimes we get patients that are call in. I'm not a dermatologist, I'm an ophthalmologist, but they send them for a differential diagnosis. This might look a little bit like EB, but it's not. This is a condition called ichthyosis, and this is another patient that was sent to me with severe eye problems, and this is another condition called xeroderma pigmentosa. It's a different condition, not EB. Now, what do we do, especially to treat our patients with dystrophic EB? Well, one of the things that's really important is to lubricate the eyes with preservative-free lubricants. There are many different types of these that are sold worldwide, here obviously in the US. They all come in these little small plastic vials, and basically those are the ones that you know for sure don't have preservatives, because preservatives, when you use them frequently, damage the surface cells, particularly in patients with EB. So my first advice is use, or tell your patients, families to use preservative-free lubricants. Now, the other thing is important. All our patients need frequent follow-up visits because they do get frequent infections of the lids and of the conjunctiva. And one of the helpful things that we've been able to do is put these patients on bandage contact lenses, because the bandage contact lens acts a little bit as a new surface for the eye. Now, the bandage contact lenses do not prevent the erosions, but what happens is that the new epithelium grows under the contact lens, so it prevents the pain, and ocular pain can be a very, very big problem. Now, another thing that's really relevant is to correct the lid position. Because of the scarring of the lower lid particularly, there's bad occlusion of the eyelids. We call that exposition keratopathy. There is a possibility to correct it internally via the conjunctiva, and if you don't correct the lid position, then these patients will sleep with their eyes open, and that creates a big problem. So that's something we have to address, to correct the lid position. And you have to treat the associated blepharitis, or else you'll get recurrent infections all the time. What we use for this as the main treatment, but it's not the only one, is topical azithromycin. It's 1%. It's sold all over the world as a drop, and gentle lid scrubs to try to get rid of this dandruff that accumulates in the lids. And the other thing that's important is to protect the limbal stem cells. That's a message for ophthalmologists in general, because one of the main reasons that this happens is because when we do surgery to remove cysts or to treat the eye for other conditions, you get rid of conjunctiva, and that conjunctiva then damages. When you remove too much conjunctiva, you damage the limbal stem cells. And then the other thing that we do is limbal stem cell rehabilitation. Now, there are different type of contact lenses, but just as a take-home message, the ones that you have to use are the ones that have high decay. Any person that is related to contact lens usage knows high decay means that they're extremely permeable. Permeable means that oxygen can pass through the contact lens, and you need decays that are over 120. These are special contact lenses that won't damage the eye, and the material has to be silicone hydrogel, because those are the ones you can leave on for a month. But these patients have to, the ones that are on contact lenses, they have to have a follow-up. For example, here you see a vascular growth over the cornea on a patient that wore the contact lens for 6 months without removing it. And so, I mean, you have to follow up these patients. And this is a tight contact lens. It looks as a contact lens edge here, but there's no contact lens. I removed the contact lens, but this is the impression of the contact lens. So contact lenses are a great solution, but you can't leave the patient on his own. Now, what are the chances for our most challenging patients, patients that have these white cornea with limbal stem cell deficiency? Well, the possibilities, I would say patients that don't have EB, is you can graft them with contralateral limbus. That means taking limbus from one eye to the other, but that's not a possibility in EB patients because they have bilateral disease. Now, if you can also use limbus from a donor, from a first-degree relative, or from a cadaver eye. You associate this with amniotic membrane, but the problem with this conventional treatment for limbal stem cell deficiency is that immunosuppression is absolutely mandatory. If you don't immunosuppress systemically, that means taking a pill to immunosuppress, then you will reject the graft and it won't work. And obviously you can imagine the risks for patients that have a skin condition like EB if you immunosuppress them, and that's a great risk. So I'm going to show you one of the two cases where I've had to deal this. This patient is Victor, and all the setting for these patients, well, this has been talked about on the different days. You have to obviously take all the cares that for intubation, for general anesthesia, and the proper setting, especially to not to damage the skin when you create and you prepare the eye and you put the drapes on. But this is here the aspect of the scar. This is a very, very severe scar in the center of the cornea. And my initial approach to Victor was, okay, what I'm going to try to do is a conventional surface rehabilitation with amniotic membrane. That's part of the surgery, and what I'm doing there is I'm trying to get rid of all this scar tissue on the surface of the eye, which you first do mechanically with scissors. I'm not going to go through the whole surgery, but I'm going to show you part of this. And what you do is basically try to remove the tissue. What I'm using there is a diamond burr to try to make the cornea smooth again, and then you put amniotic membrane. And I'll just show you the aspect of the eye. By the end of the surgery, I was pretty happy because I could remove most of the scar tissue, and this here is amniotic membrane over the surface of the eye. So I was happy. That's what it looked like right after the surgery. If you compare it to that, that's what it initially looked like, and then after the surgery, I was happy because I had that result. But as this is day 1 post-op. You see that obviously the cornea is a little bit opaque because you have an amniotic membrane on top of the eye. But then 3 weeks after surgery, I could realize that we were getting an inflammatory granuloma here, and this was an area where the surface cells, the epithelium of the cornea, wasn't growing. So that's 6 weeks post-op, and there was scarring. And this is a picture with fluorescein. Fluorescein stains the areas where there are no epithelial cells. And after 8 weeks, I just couldn't get this area to heal. I could get part of the cornea up here with normal epithelium, and then there's like a tongue of normal tissue coming from the bottom. But after 8 weeks, the cornea just didn't heal. And 4 months later, what happens is that you just start getting the scar and the blood vessels back on the surface of the eye. And 10 months, the eye looks pretty much the same as I started. So basically what's going on here is, since you don't have normal stem cells to repopulate the surface of the cornea, no matter what I do using amniotic membrane, I wasn't able to fix this eye because you need normal stem cells to get this done. So what are the new therapeutic approaches, and what has been, at least in my hands, good experience? Well, corneal transplants that we give the name of penetrating keratoplasty is not an option, because the corneal transplant needs the surface cells of the patient that's receiving the cornea to be intact, because you graft the cornea, but the surface cells are, the patient has to grow surface cells back on the corneal transplant. That's not going to happen in a patient that has severe stem cell deficiency. And as I said, limbal stem cells allograft require immunosuppression, and that's not an option. So, on the other hand, there's some things that we can do in the lab, and that is to expand oral mucosa and put that on the surface of the eye. But the problem by doing that, at least without genetic therapy, is that you just expand oral mucosa, put it in the eye, but that oral mucosa still has the anchoring disease that you get in the conjunctiva, so you're not fixing the problem. So the only real solution we have today is a surgery called keratoprosthesis. This is a model that was developed by Dr. Dolman in Massachusetts Eye and Ear in Boston. And basically what this is an optical system that's PMMA, it's a type of plastic. This is the optical part. It has a posterior plate and it goes through a corneal graft. Maybe the best way to understand this is when I assemble the prosthesis. You see, that's the optical portion of it. It's upside down. Then you place the corneal graft that has a hole in between. And then after you place that, just make sure everything is in place, and then just speed this up a little bit. What holds everything together is a posterior plate that has little holes that helps the cornea to get all the nutrients from the back of the eye, and this whole system is held together by a pin lock. And now I'm holding it. That's the side that looks into the eye, and the internal side. And then when you flip it over, you realize that's the external part of it. You see, and that's what you assemble. And now I'm going to show you Victor's surgery. You can see that that's after the first surgery I did. The cornea was completely opaque. Look at the aspect of the cornea, and you basically what you do is you have to remove the cornea, and you do that by trephinating the cornea and removing all that scarred and opaque tissue. And after that, the other thing you do is you have to get rid of the crystalline lens. That's a lens that's in the eye, because basically if you don't do that, the eye will develop a cataract. So you open that, and you're going to see in a minute how the crystalline lens comes out of the eye. and unfortunately, the contrast here isn't that good because there's too much light. But after you do that, you replace the crystalline lens with an artificial lens that's called an intraocular lens. That's what I'm placing right there. Wait, I'm not going to go back, but after you put the intraocular lens, then you resurface the eye and close the eye with the prosthesis that you stitch it in place. Now, I'll show you. This is the aspect of the eye right after the surgery. And Victor, when I did this, he's 11 now. He was 9 years old then. He hadn't seen at all for about 4 years, so he couldn't remember his mother. And this is waking from general anesthesia. The first thing he wanted to see, impressed this to me after seeing his mother, he wanted to see what a cell phone looked like because he had only heard cell phone. And I was so impressed. I mean, this boy was completely blind, and you can see him waking up from surgery, and I asked him, "How do you feel?" "Great." "And what do you see?" "Well, I see fine, and I want to see what a cell phone looks like." I thought that was impressive. That's 24 hours post-op, because imagine he could only hear the music of the cell phones. And this is a week post-op, and a week post-op, I wanted to see how well he could see. I mean, I had done this surgery in other patients, not with EB patients, and he doesn't know how to write or read, so it's difficult to measure letters. But what I did is, this is just with my iPhone. He started playing with this little snake that you have to follow, and said, "Well, that's not bad." I mean, he's able to follow the snake in the cell phone, because now he's learning how to write and read. And this is a month post-op, and that's a year post-op. And look at this, is really interesting. The only window to the outside world is the prosthesis, which you see at the center here. The rest is the cornea that holds the prosthesis in place, that is completely scarred and full of blood vessels, and that's exactly what would have happened with a normal transplant. But this is a perfectly well-centered and transparent plastic prosthesis, and this is the aspect 2 years later. This is actually a picture a couple weeks ago. And you can see that it's perfectly clear, transparent. You can see also a reflex from the intraocular lens, but the rest is completely scarred. So, and I have another patient that I didn't bring with you. I'm going to be presenting that in November because he's just 10 days out of surgery. So, and I just showed you the picture of him. He also has severe bilateral stem cell deficiency. And the message I want to give you is that, first place, treating ocular EB is a tremendous challenge, but I think it's also a tremendous privilege for any doctor that is involved, because we learn so much from patients with EB, and it requires a great dose of patience and tolerance to frustration. Not everything works, and sometimes it just doesn't work at the first attempt, as I told you, and I showed a case. But I think this is a message especially for doctors. I don't know if there are many doctors in here, but when we made our Hippocratic oath, I think some of us forget that our role as caregivers is to cure whenever that is possible. I think we're getting there in EB, but still beyond our reach. I think it is relevant to try to give relief as much as we can, but there's one thing that we can't get away with, and that is to support and encourage all the time our patients. So thank you very much for listening to me.
Thank you, Dr. Kantor. Just before I ask for questions, has anybody seen the little doggy? He's not up here. No, a real dog, yes. A real dog, he's about this big. I'm sorry.
It's okay, no problem.
Oh, here he is. We found him. This is what we were looking for. And now that we found Mika, any questions for Dr. Kantor?
I came up with a solution, but after hearing your talk, I don't think my solution's going to work. But I I have had eye abrasions for years.
Uh-huh.
Okay, I'm 52 years old. You all know that by now. But I have some additional trouble with my eye too, and it started when I was in my 30s, and I have what I call retinal blind spots,
Mm-hmm.
and it started in my right eye. And basically, if I look at your nose, this eye and your mouth is blocked out, but I can at least read between those two blind spots. That started first, and then my left eye developed it about a year later, and unfortunately with that one, the retinal blind spot is dead center. So I can't even read with this eye. I see periphery, okay? Well, so now I'm having to read with this eye, and I do wear a contact. I wear ActiView 2, and I make the maximum strength they have just to be able to read. I wear these glasses just to be able to see you, distance. I still can't see you. So the cornea on this eye is clear. The cornea on this eye is very cloudy now. I have a ton of abrasions on it. I'm wearing a contact on it, which I'm sure is now not really helping it, but hindering it, but it hurts now to not have the contact. So I had this brilliant idea one night that if you were to take the cornea off of this eye and put it on this eye, and then transfer this bad cornea to the retina that's bad over here, I wouldn't be rejecting my own cornea.
Well, that's an interesting thought, but let me tell you two things. In first place, what you're telling me about your retina, that's a condition that's called myopic macular degeneration, and it's caused by high myopia or high nearsightedness, and it's not related whatsoever to EB. I mean, you just happen to be a myopic person, and that's something that's still, there's a lot of research going on as it is in EB, and at some point we might be able to fix your macula.
Really?
Uh-huh.
Is that more likely to be fixable than the cornea?
Well, in the cornea, the issue is completely different. What I can completely assure you is that if you put your good cornea in the eye that has the better retina, which is your right eye, that cornea is going to get opaque exactly as it did in your other eye. Because what's making it opaque is basically either two conditions, or you have some stem cell deficiency, and if you put a healthy cornea in an eye that has stem cell deficiency, it's going to get opaque. Possibility number two is that you have exposure keratopathy. That means that your eyes don't close well at night,
They don't.
and that causes recurrent erosions and the cornea scars. And if you don't fix that problem, whatever you do in changing the cornea, you're going to reproduce the problem because you're not fixing actually the underlying problem. So if I could recommend anything is first see if there's a lid issue that can be fixed, that can be done with simple surgery, and fix that first. And if the cornea is really opaque, that can be fixed with a keratoprosthesis, but probably there's a very high association between high myopes and early cataract development. So maybe just fixing the eyelid, not touching your cornea, and getting rid of an early cataract that impairs vision too, maybe that on its own will improve the quality of your vision. And the other thing is that contact lenses plus the glasses you're wearing make objects smaller. By getting rid of the lens, getting rid of a cataract, things get bigger in size, and it also improves your quality of vision. So I think there are several things that you can address into and look into.
Now, will Kantor pay for me coming to see you?
I don't know, but I would be happy.
That's the next subject.
That's the next subject. Any other questions for Dr. Kantor?
So do you feel that applying the bandage contact lens to a patient with recessive dystrophic EB while they have a corneal abrasion, does it allow the eye to heal with less scarring, or it just allows it to heal with less pain?
Well, both things happen. In first place, it takes care of the pain. The other thing is that all EB patients that have erosions have to be on a permanent basis using a topical antibiotic, even if it's once a day. If you stop using that, you're going to get an infection. So you can't just use the contact lens without the supervision and without a topical antibiotic. And for most of the time, if the erosion forms and it then heals under the contact lenses, the chances of getting a bad scar are definitely lower. Obviously, if you use a contact lens and you don't wear and you don't use a topical antibiotic or you don't treat the blepharitis, then you get the worst of both worlds. I mean, using a contact lens without supervision, without contact lens, is the worst thing you can do because you're going to add an infection to a recurrent erosion. But if with the proper supervision and the proper treatment, it works really good. And the other thing, the best contact lenses are not the commercially sold contact lenses, the AccuView 2 or the Oasis. These, we're talking about special contact lenses that can last for a month because of their permeability to oxygen. But yes, I do recommend it, and I think it's a good solution.
But you need to wear them constantly?
Oh, absolutely.
Only when you get an erosion?
Constantly. In patients that have recurrent erosions, and it is a problem. We're not talking about a patient that has an erosion maybe once a year or twice a year. We're talking about patients that have erosions every week. What I do is I put him on contacts and I just have him remove the contact once a month, and you just change the contact lens monthly on a regular basis.
So then for somebody who only gets them twice a year, you would suggest?
No.
Nothing.
Twice a year, no. But yes, treat the eyelids, and yes, use ointments to protect the eyelids.
Thank you.
I think we have a chance for like one or maybe two more questions. I'm just gonna, I'll be back.
Okay, his eyes have become very severe over the last couple of years, specifically the eye that is bandaged now due to a corneal abrasion. This is the first we've really heard about using these kind of contacts. I've yet to find any ophthalmologist who was willing to even deal with the EB.
The contacts we found that were either from normal brand contacts to doctor prescripted contacts from other people or from what we've researched would do more harm than good.
Yeah, we were advised by several people that, you know, the basic thinking and fear was that it would do more harm than good because it would be creating another surface to have friction against.
I don't agree with that. I mean, if you're going to use the contact lens like most opticians like to do, which is just sell you the contact lens and get rid of you, obviously it is a big issue. But if you have follow-up visits and I mean, you can't do this on your own. You have to have, you know, a person taking care of your contact lenses and checking you at least, I would say, every 2 months, making sure everything is okay, and obviously making sure that the contact lens has the proper fit. If you just put in any contact lens and there's no feedback on how the contact lens is fitting the eye, I mean, today, with the technology available in contact lenses, you can make absolutely everything. You can make the contact lens adjust to the surface of the eye. We have different materials and qualities, and
So now, and he's one of these that, I mean, this is a weekly occurrence. And it's some, you know, so a solution like this could change his life right now dramatically.
Absolutely, yes. I think you should see not just a general ophthalmologist. You should go see a person that is specially trained in cornea and external disease, and that is usually, that we usually deal with contact lenses on a regular basis because it's part of our armamentarium, what we normally do to treat not only EB but regularly for many other conditions.
Should I just say that that may help the young lady? I have a 15-month-old granddaughter, and she had the abrasions in the cornea because of the itching and all that stuff. And she was given the lenses for a month. She sees well and everything. My question to you was, because of the eye is being pulled by another blister or something, she sleeps with her eye open. I just wonder what's the best way to make him close the eye when there's no.
Well, it's different if you have a contact lens in or out. When a person is not using a contact lens, what I usually recommend is first to start with lubricant gels. If important is if that's not going to, and there are lubricant gels that are preservative free. There's one in particular that's called Gentile. It's made by Novartis, and it's preservative free. And if that doesn't work, the other thing that does work is using Vaseline or petroleum-based ointment, like for example, Muro 128 made by Bausch & Lomb, because it also has a little bit of, it has 5% salt solution in it, and that dehydrates the cornea during the night, so it stops or diminishes the friction between the inner side of the eyelid and the cornea. So even if the eyes remain open during the night or a little bit, at least you know that there's a layer of this ointment preventing the surface of the eye to dry out. And if that doesn't work, then the option is, very gentle lid surgery that you have to do from the inner side, from the conjunctiva, not from the skin.